Okay, good morning, everyone. Welcome to another VITA Academy webinar. I'm really excited to have Eugene Roisengert with us today, talking about supported and fixed denture solutions, or implant supported fixed denture solutions. Eugene is my go-to guy when I've got denture questions, and I'm really excited to hear what he's going to talk about today.
Thank you so much, Paul. Hi guys, good to have you all here this morning. Hopefully everybody is somewhat awake. I know I am. I got like a big cup of coffee here. So today we're going to talk a little bit about implant support, implant retained restoration. So we're going to talk about planning it mostly, because the biggest issue that I see in these kind of cases is the failure to plan. You know, when you fail to plan, you plan to fail, as they say. And a lot of times, what I see in my own laboratory, and I talk to a lot of people all over the world actually, and they see the same thing, is that a patient comes in, they already have the implants placed, they go into their either general dentist or their prosthodontist, and they go, okay, I got my implants, let's get started, let's get the dentures on implants going, and at that time you're going backwards, right? Because it's very important to remember that it is a prosthetically driven implant placement. What that means is that you should be working with a denture first and then plant implants according to that denture. Now, if you look at your guys' screen, you're going to see a nice picture of me where I'm a lot younger and skinnier with a much nicer suit on. And right next to it, there's a QR code that you guys can scan. That's the link to my Facebook, Instagram, LinkedIn, my email, and stuff like this. So after this lecture, if you guys have any questions, please contact me and I'll be happy to try to answer all the questions that you guys have. Okay, so let's start from the beginning. So whenever you're dealing with patients that are, let's say, edentulous at this point, and they have a certain type of defect that is present, and we're going to be dealing, in this case, these nice pictures by Noble Biocare, you're going to be dealing with some kind of bone resorption. Either you're going to have a mild bone resorption, moderate, or severe. And according to that defect, you need to pre-plan what type of restoration you're going to be doing. Either you're going to be sticking with that particular defect and not doing any bone reduction, and you're going to be doing that type of prosthesis, or if you want to go somewhere else, something deeper, something more involved, you're going to need to do some type of bone reduction in order to accommodate your patient's needs. Okay. So with the mild composite defects, composite meaning, you know, you're missing, you know, vertical and horizontal bone loss. You're generally going to be dealing with a type of restoration that's going to be just including the teeth. You're not going to be including any type of gingiva. So it's going to be an FP1, possibly FP2 type of prosthesis. We don't generally see a lot of FP2s because it's just an elongated tooth shape. So we generally go from FP1 to FP3 type of prosthesis. But FP1 is meaning fixed prosthesis 1. We're just replacing the tooth portion of things, and otherwise called Columbus bridge. I don't generally do those type of restorations myself because it's all crown and bridge, and I tend to refer those out to the guys that know what they're doing. And in my opinion, these are the more complex type of restorations to do because you're dealing with papillas that you're trying to work with, and you're trying to make sure those papillas are shaped properly and everything else. So it's not only very challenging on the laboratory side, but it's also very challenging on the clinical side as well. Majority things that we deal with being denture labs is going to be your moderate and severe composite defects. So when you're dealing with moderate composite defects, these are going to be your either all on X type of cases where you're going to be screw retained, or they're going to be over dentures. And in my personal opinion, and I've been doing this for a little bit, and what I've seen is that I think an overdenture is actually a better option for patients rather than an all on X type of thing. And we do both of those, obviously. But the reason why I prefer, even for the moderate defect, I prefer to do an overdenture is because our patients generally have lost their teeth due to some kind of periodontal issues. Not a lot of patients lose their teeth due to, trauma. Most of it's been neglect. Most of it's been hygiene neglect and not going to the dentist, to the hygienist to get regular cleanings every 6 months or so. So they end up with a lot of periodontal disease and a lot of bone loss and losing their teeth. And we're going to take this patient and we're going to put a couple of implants in there and we're going to give them a restoration that's going to be completely fixed. That needs a lot of care because, cleaning under those prostheses is not very easy. And we're going to tell them, you know what, go ahead and do that. And these patients don't have a lot of proper reception to begin with. And they a lot of times think, well, these are implants, they're not going to decay, right? And so they neglect these things pretty easily and end up with periimplantitis and losing those implants and losing those restorations. And I think that's why it's better to have something that's removable, that's patients can take in and out and clean underneath that bar, or if you don't have a bar present, just cleaning underneath those locators, around those locators, I mean. And that's a little bit better from the hygiene standpoint. Also from the repair standpoint, it's a lot easier to do a denture repair when you can just take it out, put in a duplicate if you have one, and send that to the lab or do that right there in the office. Because with when you're dealing with a screw retain restorations, you have to uncover the screws that are usually covered with composite, take out either the cotton or the Teflon tape, make sure you can see the screws, unscrew it, put a temporary in, take that out, send everything to the lab, get it done, get it re-screwed in. It's just a hassle. So that's why I think an overdenture of some sort, it's a lot better for the patients rather than doing the whole thing screw routine. Okay. Now, another thing to be aware of is a transition line. Whenever you're dealing with an All-on-X type of prosthesis, even if you have the proper amount of room that is required for your restoration, if the patient's smile line is going to be somewhere here, right? Not on this patient's smile line is kind of low, but if we have a patient with a pretty high smile line and the transition line is right here below that smile line, well, then you're going to have an exposure where you can see where the prosthesis ends and the gingiva begins, and it does not look good, does not look aesthetic. So that's something to keep in mind, even if you do have proper prosthetic space. And this is one of the things that's often missed, and I'll be honest with you guys, being in the clinical situations, I have missed this before as well. That's why I highly recommend when you're kind of planning things out, make sure you have a checklist of things you want to do and of things you want to clear, and that checklist is going to show you every step, and you just check it off and make sure things are done properly. Okay. Now, for when you're dealing with severe composite defect, that just means that you have a lot of bone loss, and not just vertical but horizontal as well. And in those kind of cases, that you're going to have to do an overdenture, and those will need to be done for not just specific reason for hygiene, but because when you look from the profile of the patient, if you have that horizontal defect, and maybe I made a mistake actually. I think composite defect might talk about loss of teeth as well as bone, or gingiva as well as bone, as well as teeth, not the horizontal and vertical. But that doesn't really matter too much at this point. It's more of a definition. But the more important part is, and I'm sorry that I possibly made that mistake, but more important part is that when you're dealing with severe bone loss and you try to do a all-on-X type of case, and what you need to do is restore the horizontal bone loss. If you just do an all-on-X case, where you're going to end up is a nice divot going like in the area of underneath your nose, and it just does not look good. And if you try to bring out those teeth forward, you're still going to have that divot because you can't really ridge lap that area very well with an all-on-X type of case. So using an overdenture is a much better solution for these type of cases, because I've seen cases where you had a severe bone loss and patients were adamant about getting an all-on-X type of restoration, And you could see that defect pretty aggressively, number one. Number two, it causes a shelf there where you can really impact a lot of food, a lot of like lunch, breakfast, lunch, and dinner all in one. And it could cause us hygiene issues as well quite a bit. So be aware of that. So 3 different defects: mild, moderate, and severe, and 3 different type of restorations you could be doing. But like I mentioned earlier, for me, I think an overdenture would be the best possible outcome for hygiene and aesthetic purposes. Okay. Now, 2 objects cannot occupy the same space at the same time. So whenever we're designing these type of restorations, we need to understand how much space we have and how much space is required. So if I'm dealing with an all-on-X type of restoration, I know that my bar needs to have a height of at least 3 to 5 millimeters, 3 being a minimum, okay? My acrylic gets its strength from thickness. So I need to make sure that I have 2 millimeters of acrylic all around that bar, right? From either side. Because if I have less than that, I'm gonna have issues with microfractures in my acrylic. And I also need to understand that I need to have a certain thickness of the tooth present, because teeth need to be adjusted, teeth need to wear down, stuff like this. So if you're really gonna shave down all your teeth, you're gonna end up with an issue to where you're gonna need to retread your case a lot sooner than later. And also, the thinner the tooth, the easier it might fracture on as well. Also, you need to understand, with these type of restorations, patients do not have a lot of proprioception, if any. And they tend to put a lot of forces on these teeth. So you need to make sure you're using a tooth that's going to withstand a lot of forces of abrasion. And here comes the sales pitch, as they say. I personally, in my lab, I use the VITA Pen Excel and Linguaform teeth for my all-on-X and overdenture restorations, because they're a highly ceramically filled tooth. And it has the filler all the way throughout the tooth. So even if I have to reduce my tooth a little bit thinner, I still have that ceramic filler all the way from top to bottom. Now, when you take teeth that are going to be your composite teeth, oftentimes what happens is that different manufacturers do it differently. But what happens a lot of times, they'll have a composite shell, that nice and hard shell, but underneath it, they'll put a soft acrylic filler in order to bond a lot easier to the denture. And what that causes is that if you end up adjusting your occlusion too much, or your patient wears through that composite shell too quickly, you're going to end up into the soft acrylic, and then it's just going to go to town and wear out your occlusion a lot quicker. With these type of teeth, you're obviously going to have a lot more resistance to abrasion, but there is a downside when you're dealing with this type of tooth. Your bonding to acrylic is slightly minimized. That's why you need to use a product like VITA if you're in the States, and if you're in Canada, you need to use like Palabond in order to get a good retention of tooth to acrylic. And you need to make sure when you're processing your cases to properly clean the surfaces. So what I basically do when I flask my cases is I'll boil out like everybody else does, but then I steam clean everything, and then I'll actually clean the teeth out with monomer before applying VITA on top of it. And I've been doing that for, man, I want to say 5 years, maybe a little bit less, and I haven't had issues with debonding, knock on wood. All right. So when it comes to the anterior areas, also the same thing. We're dealing with acrylic, we're dealing with the bar, and we're dealing with the tooth height. Now, the tooth height on the anterior is a little bit different, because we need a little bit more of tooth present and not part of the whole acrylic bulk, because it can affect our aesthetics. So we can't really lift our acrylic that's above the bar right close to the incisal edge, because it's going to have give our patients speech impediments. Okay. All right, so this is my wonderful drawing that I've done using Photoshop, and you guys can see that my drawing skills are horrendous at best. But you can see from here that different type of components require different sizes, different measurements, I mean. So we can see the acrylic thickness right here of 2 millimeters tooth height, as I just showed you. Now, if you're dealing with an overdenture, we're going to have a primary structure being a bar. You need to understand that you're going to also need to do a secondary structure of that's going to go over the primary, that's going to be within within the denture. Now, if you are having space issues, you can sometimes replace the secondary structure with using like a fiber force mesh that's embedded within the acrylic. But most of the time, you're going to have a bar and a secondary like SLM or casted framework. And when you're dealing with an overdenture, you also need to have a little bit of space underneath your bar in order for your patients to have proper hygiene. Because I see a lot of labs will take these bars straight to the tissue and even apply pressure to tissue. But what I've noticed over the years, no matter how close that bar is to your tissue, you're still going to have food trapped underneath it, and you're still going to need to clean it. And the closer that bar to the tissue, and if you're applying pressure, you're going to have a hard time getting that super floss under it, getting those floss threaders or whatever you're going to be using underneath it in the proximal brushes. So make sure you allow proper room for things. And obviously, when you're designing your surgical guides, you need to design those guides to the bone level. So you need to be aware that your tissue is going to be 2 to 3 millimeters. So when you add all these things together, we usually end up creating our surgical guide to bone reduction. We're around 15 to 16 millimeters with those components put together. But you guys can do your own math and kind of figure out what you need for the things that you're going to be using. So this is just another drawing from Carl Misch's book on implants, which is basically, in my opinion, is like one of the Bibles when it comes to the dental implant books. So I highly recommend, if you guys don't have the implant books by Carl Misch, I highly recommend you guys get them. But this talks about different components and stuff like that. So obviously, if you're going to have a bar and you're going to have a locator on top of the bar, not a recess, but like maybe right on top of it, you need to be aware that it's going to take some room. With hater bars, you also need to be aware of components and how tall they are, things like this. So you can measure those things pretty easily. But you can see right here, I got this picture from my friends at Preet, but they talk about the bar thickness and about how much room the components take. So if your bar is, in this case, 4 millimeters, and your locator components are 3.2 millimeters, well, you need to have 7.2 millimeters of room for that particular component combination. And when you're planning things out, you need to write that stuff down. So when you're doing your bone reduction guides, that's the amount of room you're going to be reducing. Okay. Obviously, for different retentive components, you're going to have different rooms. Like you can see right here that locators are around 3.32. ERAs are going to be slightly taller, with mini arrays being 4.3 and regular 5.59. So locator is most of the time is the component that I see people use for the bars if they're using a vertical lock. If they're using a horizontal one, you're either going to see the MK1, or my personal favorite is going to be like a universal lock or Swiss lock, they're also called. The reason why I prefer that over an MK1 attachment is because you don't need a specialized tool to get in there to unlock it. And obviously you want to use horizontal locks rather than vertical ones if you have space issues. However, one thing you guys need to remember, if you just simply have a horizontal lock, you need to have some kind of backup mechanism. Because even if you have your bar at an angle, over time those things will wear out and you'll have a little bit of rotation. So I would find an area where you have a little bit or more room and put like a single locator there, or put like a Rhine 82 equator, because they're slightly even smaller than that, just as a backup down the line. You don't have to load it right away, but just down the line have that as an option, because I've made that mistake before and I had some of my friends kind of point that out and let me know that things wear out and they need to be serviceable. Okay, this is what happens when your bar is not to proper height. Like you can see right here, you have a bar fracture and this bar is actually less than 2 millimeters tall. You can see that it's quite wide, but it's only less than 2 millimeters tall. And because of that, the width doesn't really do much for you, because if you take a ruler, I don't have one here with me, but if you take a ruler, you can flex it sideways pretty easily, right? But if you flip it over where it's height-wise, it's really difficult to bend it. It's the same thing with these bars. So even if you make these bars really, really wide, well, they're still going to flex and they're still going to fracture. That's why you need that 3 millimeters of height to it, okay? And obviously use proper components for proper restoration. So this particular restoration should have been what? A locator overdenture, which would be an implant retained, not an implant supported. So because Majority with locators, majority of the forces are on the tissue, and a locator is only a retained component, retention component, because there's two of them. In this particular case, they actually used a screw retained component to a tissue supported restoration, which is incorrect. Okay, make sure you take care of your interfaces. Now, like this particular situation is not only for labs, but also for clinicians. If you're doing a chair side adjustment, make sure you're protecting your interfaces. Now, for this particular one, it's going to be a multi-unit connection, which is above the tissue, so it's not as critical. But imagine if you're dealing with a restoration that's direct to the implant component. Now, if you mess that up, that can cause major issues, not just to the fit, but also if you if you scratch it up a little bit, you can have plaque biofilm adherence and can cause periimplantitis issues down the line. So make sure you take good care of your components. Now, obviously, when you're planning things, make sure you look at things from the denture perspective. This particular case was sent to me where they took two canines, prepped them, put a couple of crowns on top of them, and laser welded some locators on top. Now, you can obviously see the height of it is just tremendous. Now, if I was to try to put a denture on top of that, these locators will probably be above my plane of occlusion. So this wasn't properly treatment planned. The proper treatment plan for this type of restoration is to do a denture first, then do some kind of matrix or a scan in order to determine how much room you will require for that component. And if you can, go ahead and get things done. Because at this point, what will need to be done is everything will need to be redone. Pretty much those crowns will need to be removed. You're going to have to prep down those canines quite a bit, and there's no guarantee you're going to be able to use locator components either. Okay, different types of bone require different approaches. Most of the time, this thing is related to the amount of implants you want to place. So let's say you're dealing with an all-on-X type of restorations on maxilla versus mandible. Now, generally on mandibles, you're going to have a much denser bone, therefore you can go with lesser amount of implants. On maxilla, your bone is going to be slightly less favorable, or a lot less favorable in some cases. Therefore, you probably want to do more implants. That's why on the mandible, they usually do 4 implants is a normal thing to do, but on the maxilla, you generally end up with at least 6. Over the years, I've seen them go away from 4 and try to place at least 6 implants in order to kind of dissipate those forces and give it a better chance of restorative survival. Restorative survival. There we go. I can't speak for some reason. But obviously, there's going to be different research studies out there. Some are going to be saying, you know what, all on 4 type of thing on the maxilla will work just as fine. But I'm just speaking from anecdotal evidence of my personal experience. Let's put it that way. Okay. Now, this picture is actually from Michael Tischler, and I love the way that he presented all the advantages and disadvantages of using multi-unit. So hopefully you guys can go through this. I'm not going to spend the time to read this all for you. But basically, the reason why I like multi-unit so much is because you're taking that connection away from the implant. And if things go wrong, it's a lot easier to fix things. Let's say, example, you broke a prosthetic screw and it's not retrievable. Well, you can always take that multi-unit abutment off and replace it with another one and get things going and get things fixed. Now, if you break an implant screw, it's a lot more problematic. And if you can't retrieve it, then it's really a lot more problematic. Now, the downside with multi-units is because the prosthetic screw is kind of small, you can fracture those a lot easier. You're obviously going to need more room for the components, because even if you're doing angle correction, right? So the more angle correction you're going to be doing, the more the taller your abutments are going to be. So these things are kind of come into play. But we've been doing majority of our cases with multi-units, and we've been pretty happy with the results so far. Okay, this just shows a couple of different attachments and the heights that are required for those attachments to take place. This slide is also from my friends at Preet. Okay, so the good thing about locators, locator components, if you get the genuine ones. Now there are a lot of aftermarket variations of this, but the main thing about locator components is there is a rotation to them. So what that allows you to do is, if you're doing an implant retain type of restoration, which supported in the tissue and just rotated by these two implants, it will rotate about 10 degrees within that metal cap. So when you're putting pressure, because your tissue that's sitting over your bone, it's got some sponginess to it. So when you're pressing on that denture, the denture will slightly rotate. Well, these caps will allow for things to rotate nicely around those abutments and retain the denture, but don't wear out the nylons as quickly, and they don't wear out the abutments and cause issues with your implants. Okay, when you have more than two, it becomes less tissue supported and more implant supported. But that insert is still has some rotation to it. It won't work very well, obviously, when the patient's biting down, because it's kind of locked in by those implants. But what it basically does, that rotation allows you to easily insert that denture intraorally, and it doesn't wear out those nylons very easily. I've run into that specific situation before with custom-made abutments, and where I was using their locator components, and because of that, I wasn't able to insert those a lot easier, and those nylons wore out quite a bit because of that. Okay, now locators have a certain divergence to them, but I've noticed that O-rings are a little bit more divergent, and it's a little bit easier to work with those. And sometimes I'll actually work with combinations of locators and O-rings as well, like in this particular case right here. So and I have to do more with passive insertion rather than retention, because in this anterior area, my locator was pretty straight on. But on this posterior area, the angulation of implant was such that it would have caused some issues of putting things in one path. So we actually ended up putting an O-ring, not an O-ring, but what's that? A ball attachment in this particular case. Sorry, I misspoke. And I'm able to kind of correct that path of that ball attachment secondary to make sure that's in line with the locator. And what you basically do after that is you just lock it in the spot with some stone, and you can just process everything together, and now you have the same path of insertion for both components. And also, it's a little bit easier to work with these if you're in the interior area, because locator is only going to be going in from that point right there, right? But with a ball abutment, you can actually rotate it inward slightly and get it away from the tooth, from the facial, to hide things a little bit better. So that's also a benefit of doing it that way. Okay. Let's see if how we're doing on time here. We are about half an hour in, so we're good. All right. So another component to remember is the AP spread. It's a fairly important component, because the way we usually measure AP spread, it goes from the middle of the most anterior implant to the distal of the most posterior implant. And we measure that distance, and timing that distance, not timing, but multiplying that distance by at least half, or all the way up to, I don't know, 1.5, gives you that AP spread cantilever that you can use not for all the restorations. Now, for example, if you're dealing with a locator fixed type of restorations, they don't allow for any kind of cantilevers. So sometimes you just have to stop at that most distal implant. But this picture here in particular kind of shows you that these measurements sometimes are done wrong, because a lot of times people will measure distance on the longest side and they'll transfer that over to the short side as well. Well, that's not necessarily correct. What you want to do is you want to measure that together on both sides, and then you know that you can actually cantilever. In this case, we're using a 1.5. You can cantilever this much here, but a little bit longer here. Whenever I kind of deal with this type of situation, I usually only cantilever about this much, because patients don't generally like when you have, let's say, 2 premolars and a molar on one side, and then you have 2 premolars or 1 premolar and a molar on the other side. They like symmetry on both sides, so I try to keep it short on both sides if that's the case. Plus, also kind of minimizes torques on those implants as well. You might not be breaking screws as easily. All right, I want to talk a little bit about, I kind of skipped over a bunch of little things, but I want to kind of tie it all together for you guys into a protocol that I generally use and modifications to that protocol. Okay, so when I say if you like puzzles, you know, removal restorations period are a big puzzle. They're one of the hardest restorations you're going to be doing when it comes to your patients, because you're dealing with a blank slate. You know, you have to build up everything from nothing. So, but when you start bringing the implant component into it, it becomes even more difficult. Okay, so one warning that I want to tell you guys, and that's the reason why I have this model here. Printed models are great, and I get a lot of really cool resins nowadays, and I get really, really precise printed stuff, but be very cautious, because even if you print the model today and it looks great and everything's working perfectly, if you modify it some way, like for me, what happens is that we actually poured mounting stone into these models, and the moisture from that has distorted the printed stuff. So always have some kind of a backup in place. Now, if you're doing like a fully digital protocol where models are just for kind of a show, that's a different story. But if you're verifying stuff on a cast from the mouth, then it becomes a little bit of an issue. So this is a newer thing. Not a lot of people are still using it. So just be aware, even if you print, like this is like a really cool model with really nice resin, but you need to treat it properly, proper post curing procedures. And if you're going to be doing some kind of mounting, try to have the stone away from the actual model, okay? All right, initial planning. So basically, how do you start a protocol for implant, retainer, and implant supported restoration, a denture, right? You start like you do with any regular denture. What you basically will do is you take an initial impression. You're going to do it with an alginate, you're going to do it with polyvinyl, or you can even do an intraoral scan. It's up to you guys. From that point, we're going to fabricate a custom tray. This one was done in analog. I do most of my stuff digitally now. Majority of my custom trays and my base plates, I scan and print nowadays, and I haven't been this happy in years, because if I never have to block another model by hand with wax, they'll be awesome. Because with digital, I can just block out at 3 degrees, and it's always a good block out, good path of insertion, unless my resin shrinks too much or something like that. But that can also be adjusted down the line. And I have had really good results with taking impressions with these type of custom trays, and my base plates are nice and clean, very nicely adaptable. So things are going well. From there, you take a final impression. Obviously, you're going to make a wax rim, do your bite registration. Now, especially when you're going to be doing stuff down the line that's involving that involve, for some reason I can't speak today at all. I keep mixing up my words and things like this. I highly apologize, guys. I'm sorry. It's bad enough that I speak with a Russian accent sometimes, especially when I start getting nervous. It also sucks when I start mixing up my words. But I digress. Whenever you're going to be dealing with a restoration that's going to be down the line implant supported or retained, it's very important to make sure your articulation and your occlusion is dead on. Because if you are off on your bite and you're off on the position of your teeth, and you use that to fabricate your surgical guide and load your case, then down the line you're going to realize that's not your bite, and you have to move your teeth around, and your implants are in the way, then you're going to have some major issues. So that's why I highly recommend doing a Gothic arch tracer in order for you to guys to establish your centric relation. And if you do that, you're going to have a lot easier time down the line with your occlusion and everything else. Okay, so you do a try-in, everything looks great, you're going to go ahead and process that case. Once you process this case, you're going to either fabricate or use that denture as a scan guide. Okay, there's a couple of different scan guides that you can do. Like if you have an existing denture the patient likes and everything goes well, it's a very well adapted. Even if it's not fully adapted to the tissue, you can do a reline, either a hard reline, or you can do a chair side reline with some radio opaque material. And you can use these fiduciary markers. These are basically just stickers, and there's a zirconia ball inside of them that you can stick on top of the denture. And you want to use at least 6 of these markers, okay? Another thing you can do is you can just take zirconia bowls that we oftentimes use for sintering, and you can use a little bit of optiglaze to connect it to the denture. They stay on pretty well, and you can pick them up pretty easily afterwards and just give them a polish. So that's the second thing that you can do. A third thing will be to duplicate a denture and to put in either gutta percha or some kind of radio opaque material within it. So you can be using composite, gutta percha, zirconia, whatever you want to use. Okay, and these, all of these three that I've listed so far, these are utilized in order to do either a double scan protocol where you're doing a CT scan, or do a CT scan and just scan the denture with those markers. If you want to do a single scan protocol, you would have to do something like this, but I generally don't see this very often anymore. This is a barium sulfate filled tooth. So basically, when your patient puts their denture in, you just do the scan with those and use that to line things up. You're not going to be scanning those dentures with a secondary scan, as far as I understand. Personally, I've only done one of these scans, I think once or twice, and I don't really know exactly how things are working out with this, if they scan these with an intraoral scanner afterwards or not to line things up, or they just simply start using the CT scan from there and measure from the barium sulfate. Measure from the barium sulfate inside those teeth. But my understanding is it's just one and done kind of thing. From there, once you've taken your measurements with your scan guides. Oh, another thing I wanted to mention, when you're using these type of scan guides with fiduciary markers, it's a double scan protocol. So you're either going to be scanning inside the mouth, and when you're scanning inside the mouth, you want to make sure your patient's biting on some cotton gauze or cotton rolls in order to make sure that you have a little bit of space between the upper and the lower denture, so they're nicely visible. And you want to put a couple of cotton rolls around the denture on both maxilla and the mandible, just to keep the soft tissues away from the denture, so you can be there's no, you can easily visualize things. So later you can either scan the denture on the CT scan by itself. You usually just switch the CT scan to a VITA setting and scan it that way, and you can merge those files. Or you can just scan with your intraoral scanner or lab scanner. You can scan the denture and merge those files that way. But you have to make sure when you're scanning the second time around, you still have those fiduciary markers on the denture. Okay, hope that makes sense. If you guys have any questions, don't hesitate to ask. I'll try to answer it to the best of my abilities. So once you have the scans, you can go ahead and take a look and see the position of the teeth in relation to the bone. And you can take a look there, and you can actually see what would be the best place to place those implants and how much bone reduction you will need to do. So when you're making your surgical guides, you can make a notch on your surgical guides to tell your doctors to which area, like on this line right here, to which area to reduce the bone. I've actually stopped doing surgical guides that way because it kind of confused my surgeons, because they couldn't tell, do they need to reduce the bone here or to here? So nowadays I'll just kind of stop my guide at this area and just have the whole thing kind of resting on the palate, and then the surgeons can actually tell a lot easier to where they need to reduce it. And also this kind of keeps the tissue out of the way a little bit. All right. Now, if we're dealing with a patient that presents this way, right? If they have an existing denture, and we've just talked about like using an existing denture to create our scan guides, create our surgical guides. But if we have a denture that's very poorly adapted, it's going to be very difficult for us to create a good surgical guide, right? Because we obviously don't want to give our patients a final denture that's going to look like this. We want to give them something that's going to have proper occlusion, proper aesthetics, proper phonetics and function. Okay, so it's very important to take the patient from this stage to a proper denture stage, and then and only then start planning things properly. Okay, now you can duplicate dentures the old-fashioned way. This is how I used to do it, either using just silicone in the flasks like this, or in this case, I was actually using alginate. And I'll be honest with you guys, using alginate on these things didn't work very well. So you can still use these kind of flasks and do them analog, but with silicone. That's what I would recommend. And also, if you're using this type of flask to duplicate with silicone, make sure you block out that undercut that's under there. and I usually just use stone to block that out, because if you're going to use silicone, especially like heavy body silicone, and trap that undercut in there, you're going to have a really difficult time getting rid of that and taking that out. Okay. Or we've actually used, this is a soap dish that we've used to use a duplicate, to make a duplicate. The other trough in your surgical guides is going to be on the palate. Like I showed you one for the bone reduction, that's going to be on the facial of your surgical guide. But this one right here is going to give you a guide of approximation where you want to place your implants. It doesn't give you an exact position. It's not like a fully guided protocol. It's a duplicate denture guide protocol. But the surgeon can take a look at this and go, okay, well, I can put one here, one here, one here, one here, or put 6, whatever works for them. And this just makes it certain that the access holes for the denture don't go through the facial of the actual denture. And it gives them a guide to where to put multi-unit, angle multi-units and stuff like this if they need to do. Nowadays, I actually put a little piece of material right here to make sure, kind of to cover the incisive papilla so it doesn't get drilled into, and also gives it a little bit more strength and stability. So this is actually an older picture that I was using before. Okay, so this is our surgical guide. Now, if you want to do a fully digital protocol, the idea is still the same when it comes to the scan guides and everything else, right? So you're going to be doing your denture with fiduciary markers. You're going to scan that in, and you're going to overlap everything together. Is just when you're creating the surgical guide, it's done completely digitally. Now it's going to have a couple of different components. This component right here is going to be for your bone reduction, and this one is actually going to be for the implant position. So obviously these are going to be a lot more involved, where you're going to have to lay a larger flap to get it down onto the bone for the bone reduction and positioning. But some of them are more involved, some of them are less. This particular one, you support it obviously with some bicortical pins and snap things on there in order to place implant positions. These work fairly well. This is what it looks like for most of the cases that I do. Basically, I take a scan of the denture, I bring it into mesh mixer, and I cut out 2 areas for the approximate implant position. And as I mentioned earlier, I have an area that covers the incisive papilla for 2 reasons: to stabilize the base and also not to accidentally get into the incisive papilla area for implant placement. And nowadays I just print them. Now this particular one didn't have any bone reduction done yet. I used to do this by hand. I would still print the trough portion, but this I would do by hand. Nowadays I actually do it all digitally. Okay. Now, if you're dealing with a situation like this, where the doctor provides you with a patient's existing denture and looks like they're just tried to raise the bite chair side, and they took a quick wash impression and decided to do the immediate denture from that standpoint and the surgical guide right from there, I highly, highly, highly recommend you guys don't do it that way. If you're going to be changing this many parameters, make sure you fabricate your patient's denture first. Make sure the patient is wearing that for at least a little bit. Make sure you dial in your occlusion and aesthetics first, okay? And then fabricate your surgical guides. Because for this particular case, the situation we ran into, because we did everything so quickly without checking anything, and we placed implants according to this position, well, when it came time to actually do a final restoration, the occlusion ended up being off. The position of the teeth ended up being off. So we started moving things around, and then implants started being in the way and causing a lot of issues, okay? We were able to fix them down the line, but it still caused a lot of issues. So when you're dealing with immediate type of restorations, let's say patient is fully dentureless and you want to go straight up and straight away get things done, or patient is partially dentate, make sure you prosthetize them first, dial in that occlusion, and then place the implants. Because when you're dealing with full mouth reconstruction, things tend to bounce around, things tend to change. And I understand that your patients are very adamant about wanting things done right away, but I'd rather wait and get things done right than having to fix it and horribly, horribly mess things up down the line, okay? I actually have duplicate slides here accidentally, sorry. So once you utilize your surgical guide to do proper bone reduction and for proper implant placement, A lot of times what we will do is we'll do a chairside conversion, right? I don't personally do chairside conversions. I've done a couple of them in the past, so I'm not exactly an expert in that. And the reason why I don't do chairside conversions is that there's people that are really good at it, and they spend their entire time doing that, like my friend Dora. Her entire business is she does conversions, and she loves doing that, and she's really good at it. For me, I like to utilize my time doing something else. So I've only done a couple over the years. But nevertheless, let's talk about them a little bit. So basically, once the implants are placed and you have some kind of cover on top of the multi-units, if you're using multi-units, then you want to take the denture that you fabricated and access those areas, drill those holes out for you to pick it up chairside. Now, what I used to use is just use some bioregistration material inside the denture just to mark those areas and drill them out. Once you do that, make sure you check the length of your tie bases, make sure they're a proper height. If they're too tall, you need to reduce them. But be aware, I actually became aware of this fact because of Dora. She did a webinar on this, and I was fortunate enough to listen to hers. And she says, you know, if you have to cut a lot from those tie bases, from temporary titanium cylinders actually, then you probably didn't do enough bone reduction, because those things are about 10 millimeters tall, and that's how much room you need for the bar and everything else as well. So if you need to reduce a little bit, that's just fine. But if you're having to cut quite a bit off of those, then you're going to have a problem. And obviously, you don't want to cut those off inside the mouth. You want to take them out, mark them inside the mouth, cut them, and take them out and cut them. Once you have them cut, make sure you protect the area. In this case, I'm using rubber dam. Make sure when you're opening up access holes for these areas, make sure you don't have any impingement. Like if you look right here, I have one of the titanium cylinders hitting the denture and here as well. So you want to make sure to open it up even more when you're picking it up, because it can become askew and cause some issues. Block out the access for the screws with Teflon tape or something else. Some people will use toothpicks. If you're using a toothpick, make sure you, or a Q-tip, make sure you put ample amount of Vaseline on there so it doesn't get stuck on the acrylic. And especially if it gets stuck and it breaks in there, you're gonna have a hell of a time trying to dig it out. All right. A lot of times, because these patients are not fully under, but they're consciously sedated, you're gonna have a hard time for them to find their bite. So a lot of times what we'll do is we'll get some kind of a splint made beforehand that will align their bite a little bit easier when we're picking up these locators, not locators, I'm sorry, these tie bases chairside, okay? So once you get things picked up, go ahead and smooth things around, and then from there, you need to do a couple of things. You're gonna have to obviously reduce these borders, and you need to make sure you don't have any cantilevers. Now, half a tooth of a cantilever is okay. Any more than that, you're gonna have issues. Another thing, what you need to do is make sure you do not have any ridge lap, because you wanna make sure you're properly, have proper hygiene and you can properly take care of these dentures, okay? Also, make sure you reduce the cusp height. You wanna make sure you have a nice and free movement laterally, because any kind of lateral forces on your implants can cause implant failure. So make sure to reduce those cusps quite a bit, and make sure to tell your patients to keep a soft diet, because as one of my prosthodontist friends says, you want to make sure your patients don't eat anything harder than boiled fish. I don't know how much you can eat boiled fish for, but you know, that's one of the options. So once you get that done, you can send your patients home. Now, if you can't load the implants, and say, for example, you didn't get the torque that you needed, that's why it's so important to have a backup plan ahead of time. Now, if you're dealing with a conversion case chairside, now you're going to have a denture there to begin with. But if you're doing like a fully guided protocol, a lot of times those just have the perforations for those implants that you're placing, and now you can't pick that up. That's why I always prefer to have a full denture still done for the patient to wear. And nowadays, a lot of times what we'll do also is place a couple of mini implants just for the retention purposes, and have those there while the main implants are also integrated. Now, I haven't seen them use those mini implants for cases that are fully guided. Let's say, for example, you got a fully guided restoration, right? You have the holes pre-drilled into the printed or milled restoration. You're going to pick it up right from the start, and things don't go right. technically, I think you can still use that and pick it up with mini implants, but I haven't seen that done before. Somebody's probably doing that. It's just I haven't had the pleasure of seeing that before. Now, if you want to convert that case not chairside but in the lab, that's a more European way of doing things, I would say, because I see that done quite a bit overseas. We're starting to do that here a lot more as well. But for us, I see that more like a permanent conversion type of thing, not a temporary one. For the conversion lab, you basically, what you need to do is you need to get some kind of impression. So if you have a good surgical guide, like a duplicate denture surgical guide, you can use that to take the impression with some impression copings. And you want to use some kind of material that's going to be slightly more viscous. You don't want to be using light body impression material because it's going to go flow everywhere and cause major hassles. So, and you also want to protect your sutures somehow. A lot of people pull Vaseline on there, but I still see people pull sutures all the time. But from there, you're going to end up pouring up a model, usually right there in the office. And then you're going to have to do a slight conversion. It's not a full conversion, but what you basically need to do, you need to make sure to transfer that occlusion that's in the patient's mouth onto the model. So instead of picking up all 4 tie bases, you're going to pick up 2 anterior ones because they're going to be the easiest. And then you're going to transfer that onto the model using the same kind of components. So in this case, I'm showing you 4, but you only really need to pick up 2. Same thing, you want to have some kind of splint, or if your patient's fully aware, they can bite into their occlusion. I've done splints like this before too, just out of silicone, and mount them, the whole denture with silicone. I've done splints where I've done little occlusal splints on 2 sides and bonded them together. So there's a couple of different ways you can do it. This was a way we used to do things. Let's say, for example, you want to convert the case, not chairside, but in the lab, like I'm showing you guys. But the patient is going to be going without a denture for a day or 2. When it was it used to be kind of a problem to duplicate dentures because we used to have to do it by hand. It's kind of a hassle. So what we would do is we create this little jig right here, just to kind of to keep the pressure onto the tissue while we're fabricating a denture. So something that can be done fairly easily with an acrylic or light cure material, and it kept pressure on the tissue to make sure it didn't swell too much. So when you go to actually deliver your final case, it didn't, you didn't have to fight it as much. But nowadays, it's a lot easier just to create another duplicate because we can just scan the denture in and print a duplicate in a couple hours without having too many issues. And because of that, we stopped doing those kind of jigs. Okay, but in the lab, you're going to have your titanium cylinders, you're going to have your setup. You're basically going to use some kind of reinforcement. Now, in this case, I was using fiber force rope, but a lot of people like to use cast metal, or nowadays I like to use this. This is actually a trilar arch that you can shape by hand. You don't need a milling machine, and these are really, really strong. So if I'm doing a long-term temporary, for example, I will definitely use this type of material. I've had good results with it. But basically, you wax everything up. You try to address the tissue on the model. Your temps are the best time to address the tissue, because if you want to compress and shape the tissue, you want to do that with your temporaries. Because if your temporary is wavy like this, your tissue is going to be wavy like that, and when you try to do your permanent, this is going to create major issues down the line. So address it. In this case, I'm just using this kind of silicone abrasive wheel to shape it down, to make sure it's flat as possible. Now, obviously, these models in this particular case is a demo case. Nothing looks that way in the mouth, but the idea is the same. You wax it up, you inject it, or you press pack, or whatever you're going to be using over that bar, and now you have your patient that's going to wear a temporary denture for a certain period of time until the implants fully integrate. Usually it's around 4 to 6 months is what we usually have. Now, from that point, you need to fabricate your final restoration, and there's a couple of ways of doing that. Basically, if your patient is happy with their temp, you can do a chair side and send it to the lab, and there's 2 ways of doing that. Okay, this particular case is not the best example, but I was present chair side for this case, and I kind of did the steps. But what you want to do, obviously, with this case, you probably want to do a little reline impression within that denture first to make sure to get a proper representation of the tissue underneath the denture. Once you do that, you will do a pickup impression of the denture in the mouth, as you can see right there. And once the denture is inside that pickup impression, you're going to need to do some kind of soft tissue portion on top of your reline impression. Okay. Once you've done that, this is what the soft tissue looks like. You're going to go ahead and pour up everything after it's been boxed up. So it's a little bit involved when it comes to clinical steps. Let's put it that way. Okay, once it's done that way, everything's boxed up. This is what it's going to look like. And then you need to make sure to put some kind of keys on your model so you can actually interdigitate things a lot better with your matrix you're going to be making. So what you basically do is you fabricate a putty matrix that fits over the top of that. And it looks just like that. So from this point, you have your model. Obviously, it's not a verified model, but it's a good model for the position of the implants. And you have the position of the teeth. This is what it looks like, and you can just send that to the lab. The lab will basically create a replica of what the patient had. What I used to use was heavy hard wax, the jeweler's wax. So, and that's the reason why I took these titanium cylinders and I bonded them together with some pattern resin. Because if you're just going to be using wax, it's not hard enough to keep everything in place, and it's going to fracture around things. So you want to have some kind of reinforcement around the titanium cylinders, and then you inject this very hard wax into the putty matrix and create a duplicate that looks like this. And from there, you can actually set up your teeth and do a try-in, obviously with verification of the model as well. Okay, but what we started doing as of late, so the doctor, this is an actual case that the doctor sent me. So they did everything chairside. You see these keys, you see that. So they want me to do what? They want me to verify this this model, make sure the position of the implants is passive, and then they want me to create a new setup. So instead of injecting wax into it, what I started doing is I started scanning inside that matrix and printing just a basic tooth setup from converting that scan. And I covered the implant holes, the abutment screw holes, with some tape just to make sure things don't get into that. And I connected everything with wax, just like this, and mounted it and did the setup and send it to the doctor. So when I'm sending things to the doctor, they're going to try in that setup, make sure that it works out, but they're also going to verify that cast. And oftentimes I do a verification jig made out of stone. The reason I do my verification jigs made out of stone is because I like to make sure I have the most passive fit. Stone doesn't flex. It tends to snap pretty easily. So if your implants are not perfectly passive or your abutment connections are not perfectly passive, it will snap on, okay? So basically I make a matrix like this and I'll block out underneath with wax and I'll pour up stone, as you can see right there. And I actually will give them a custom tray with that. So what they will be able to do if the stone jig snaps, and the stone jig is actually covered with OptiGlaze or some kind of light cure glaze, so it doesn't absorb moisture. So if it snaps, you can load it together with composite or pattern resin and take a new impression. But if you look at my setup, it's actually on locators. I use these little conversion abutments from Blue Sky Bio. They will convert from multi-unit to a locator. And there are a couple of reasons I do that. It makes it a lot easier to do bite trims, to take them in and out. You don't have to screw things in and unscrew them. And it's a lot easier to do try-ins as well. But if I take a new impression and I pour it up, it's a lot easier to transfer that to the new model because it's a resilient type of attachment and it's not going to be bouncing all over the place because the position of implants is slightly different. Okay, that makes sense? So that's what I send them with a try-in, a verification jig, and a custom tray. But lately, what I started doing, and some people have been doing it for a while, but I just recently started doing it this way. What I have the doctors do is when they send me the impressions, they just take regular impressions. They don't do anything chairside for the model work. They'll take regular impressions. I'll box it up and pour it up. And you can see these little magnets that I use. That is used to make sure that the tissue kind of stays in place a lot better on the model. But you can also, I do it in combination with with an angle. So I kind of lock at a 45-degree angle of the tissue, but also um, the magnets kind of keep everything in place. Because I like to keep my tissue going going back quite a ways, because especially if I'm transferring one setup from one model to another, I want to make sure it's got a little bit of gift to it. So if I have a little bit of discrepancy, it will still fully see. Hope that makes sense. Okay, but I have them do a 360 scan of their temporary, and I print that. And what I use for this is actually packed dent resin. The reason why I like this particular resin for printing is because it's when you drill on it, it doesn't like chip like everything else. It's very very easily drillable material, and you can cut through it pretty easily as well. And what I basically will do is I'll cut the areas around the actual connections, and I'll use long pins to connect it with some pattern resin to the model. Now, if the pins are too long and interfere with my occlusion, I can just cut the pin in half and put like a little notch in there for a regular small screwdriver, like for the eyeglasses, and use that to screw it in. And what I basically will do is just connect it where it's connecting and mount that up. Now, obviously, you can see right here, it's not a perfect connection, but it's still better than doing a bi-trim, for example. The reason why it's not a perfect connection here is because the impression wasn't properly done, and the position of these implants wasn't properly captured. You can see on the bottom it's properly captured, so we had to actually take a new impression and reset pretty much a little bit. So we did that, but overall, doing that is a lot easier on the clinician, because all they have to do is if they have an intraoral scanner, they can just scan the 360, take the impressions and send it to me. They don't have to mess with pouring up stone, doing soft tissue and everything else. And when I send it back to them, for this particular case, they got it mounted to the Cois analyzer plate, but I had to kind of move things around a little bit on here. So that's why I use that printed table, and it's actually an FDM printed table, which I can actually heat and switch things around. Because a lot of times what I see clinicians do is when they try to capture the position of the horizontal plane with the Cois analyzer, they really mess up the camper's plane. And I get two setups that are like this or like that, but the horizontal plane is on. So I have to adjust that plane to that plane with the table. And by using these printed ones that I've created, I'm able to correct the camper's plane and set things up a little bit better. So basically from this point, I'll send the doctor the setup. They can try in, and I'll send them verification jigs, which as you can see are glazed and custom trays, okay? And from there, they can verify things. And if everything is verifying and everything looks good, we can start fabricating our bars. Now, if we didn't do that, if our setup was just completely bad, if we didn't have a temporary, the patient was just wearing a regular denture, we're gonna have to start things from the beginning, right? So basically, if they didn't like this denture or they had a regular tissue denture, you need to take some impressions. Now, there are two ways you can do it. For the doctors that I work with that are not very knowledgeable from the standpoint of the protocol of impression taking, I kind of try to simplify things for them a little bit. And what I basically will do is I'll tell them to take a close tray impression where it's just, they don't have to drill a tray or anything else. They just do a close tray pretty easily. And then I'll just put that inside the impression, and I'll pour that up. And I use that as my initial impression. So I know with implants, we generally don't do initial impressions, but with this technique, you will. So basically, they'll send that to me, I'll pour that up, and I'll create an impression jig, not a verification jig, but an impression jig. It's something that's just solid enough that we can lute together to take a much more reinforced impression to make sure things don't shift on us. Now, is it a necessary step? No, it's not. You could a lot easier just do the whole thing by yourself by placing those impression copings intraorally, cutting into a tray, luting things up with some floss, and putting some pattern resin or some light cure pattern resin, and do that all chair side. But some doctors don't have those expertise and they would rather do something more simple and send it to the lab, so I give them that option. So basically, I'll mark everything for them, they'll lute it together with some jig gel or some pattern resin, and they'll take an impression. Another downside of doing things by yourself and not utilizing the impression jig that I fabricate, when you're doing intraorally, you have a hard time of telling how much thickness you've placed between those impression copings. And in this case, you can see that it's less than 2 millimeters. So it still has some flex to it. And for this particular case, when the doctor took the impressions and we made verification jigs, the model was not verified properly. Okay, so we ended up having to take new impressions and make new jigs. So something to be aware of. So that's pretty much what they do, is they just take a tray, they cut into it, connect it with floss, or they don't connect it with floss, and just take an impression with that. Okay, I really like this particular system. It's called an Easy Bar. Basically, it's just got a bunch of different sizes of bars that you can connect together intraorally and take an impression with that. If you do this particular system, you don't have to have a stone verification jig, guys. Like, I've done cases like this, and I've went straight to the bar from that point, and they've always fit pretty well. So basically what you do is either on the model or in the mouth, you measure the distance between them, get the right sizes, and then you connect them together. Now, if you're doing it in the lab, you just send it in, the doctor puts it in, takes an x-ray, make sure it's all passive, and you're good to go, your models are verified. Or if you have the kit in the clinic, you pretty much connect everything in the clinic, take the impression, send it to the lab, and I go from this point straight to the setup and bars and whatever, okay? So basically, we have this verified model, not verified model, we have this model that we need to verify it if we don't have the metal jig. If we just have them connected with the impression jig, I still need to make a stone jig or a metal jig from that standpoint. So basically what I'll do is I'll try to go to the next slide. There you go. Basically what I'll do is I'll make a stone jig or a metal jig. I block out everything in block out putty and some lap putty as well. And from there I'll pour up type 4 stone, low expansion type 4. So this particular one has an expansion of 0.06 or 0.08 % expansion. I use the Fujirock either IMP or EP dental stone, and it's a very good stone that can be used for implant components. So both the model and the jig is made out of the same stone. I shape it to make sure I have enough room underneath, so if the stone jig fractures, I can actually lute it together and inject the impression material underneath. And I give the doctor a custom tray, okay? And at the same time, we'll make some bite trims, also tripodized, like I showed you guys with those locator components. And then if it snaps, they just lute the whole thing together and take new impression. I'm not gonna do the video, I don't have time for that today. Okay, so once the model is done, we're gonna do a setup on verified model. And when you're dealing with cases where you're going to be doing, for example, I started doing more cases with zirconia crowns, whether it's a thimble bar or a full zirconia arch, you're no longer dealing with denture teeth, right? So you want to really make sure your bite is dead on. So for those cases, we started doing prototypes. And those, since we started doing printing, those became a lot easier. I still do printing and milling, but you basically just take that setup, convert that into a digital, you print it, and you have the patient wear that. So this one's just modified. Send that in, have the patient wear that for a while, make sure you like the aesthetics, make sure you have good adaptation, you have good occlusion, and then once it's all dialed in, you get it finished up and you get the zirconia stuff done, okay? For bar fabrication, this is, oh, you can't see my computer screen. How about now? Sorry, I think something probably happened. Oh, good, okay.
I can see it. Is there anyone else who can't see the screen?
Well, oh, it's Marina. That's why she couldn't see it. She's from the same city I am, so she's probably day drinking. So we're famous for that back in Odessa, so. No, but I'm kind of running a little bit short on time, so I'm going to speed up a little bit. Basically, once you do the setup, you need to fabricate your bar. And a lot of times, what people will do is they'll just send a setup and get that scanned in. And when you do that, it causes some issues because you don't know where the basal surface of the tooth is. So what we started doing is, initially what I started doing is just peeling teeth off away from the setup without properly heating it and causing this nightmare. So in order to fix it, what I started doing, no, I can't, I'm on the wrong screen. Ah, man, no, not actually froze up on me. Wait for program to respond. Sorry, I started switching between screens and it caused my PowerPoint to freeze up. Well, let me start explaining things while it's actually starting to connect. What basically happens is that when you are just scanning the tooth setup and you're not getting the basal surface of the tooth scanned, what basically happens when you're designing the bar, you know where the tooth top is, but you don't know where the basal surface is. So you're, a lot of times you're going to end up with a bar that's hitting the teeth too much, and you're gonna have to adjust it. I'm still not able, for some reason, let's see, still frozen. I'm still not able to get this done. But what I started doing, hopefully you guys can see this picture, what I started doing is I actually use these verticulators, which is basically an articulator that goes up and down. So what I started doing is actually taking those teeth off the setup and then putting a little bit of wax on there and just pressing those teeth in there and using that as the area that I would scan in to show me where I would need to stop the bar. What I didn't realize at the time is that what I could have just done is scan this as my model without any wax and scan this as the opposing, and the software would just put the teeth right over the model and I would know exactly where that is. But I didn't figure that out till much later. So I had to take all these extra steps for a while, for a couple of years, to get that done until somebody actually showed it to me. So that's what I would used to do. I would cover the teeth, tops of the teeth with some crown and bridge material to make it more stable. And I would do a putty matrix on top of that. But then after a while, I started thinking, well, what if I just print these little splints that go on top of the teeth? And I can actually incorporate that into the wax body and skin things a lot easier. And then it kind of progressed and I went, oh wait, I can just make these cages that fit on top of the models and I wouldn't even need an articulator altogether. So basically I started printing these cages that fit on top of the models where I can actually take the teeth off, scan the teeth, design my bars, and once the bars are designed, I can actually reset the teeth on top of the bar without using any other contraptions. This is what they look like right now. Okay, and you can actually see a lot better with this type of scan, and you can measure things, and you can see right here we didn't have proper room. So I can actually measure things and tell the doctor, well, we can do a bar on this side, but not on that side. And we need to change restorations if we need to. But you can do a couple of different bars. You can do mill bars like I like to do, or you can do SLM bars and just cement them directly to tie bases if you wanted to. But make sure if you're doing cast bars, don't get them cast directly to the implant components for a couple of reasons. Number one, usually casting out of chrome cobalt, and you don't want to connect chrome cobalt to titanium because two different abrasion hardnesses. And also they just don't adapt very well. And the second thing, even if you're milling things, make sure you inspect it very well. I usually use a microscope to inspect it. Like you can see there was a wobble in the burr, so it didn't fit very good. Look at this multi-unit, really bad attachment as well. So they should be looking something like that when you're doing properly. Okay, you can do tri-lower bars if you wanted to. I generally just prefer to do titanium. You can do a combination of wraparound and single crown cases for when it's not, you don't have space, but you want to save a little bit of money. But as you can see right here, if you get everything scanned in and designed properly, the teeth will fit over the bar pretty nicely. Okay. From this point, what you need to be doing is you actually need to opaque your bars. I usually opaque my bars before I do a reset on top of them. And some people will say, well, like, if you're doing that, you're contaminating your opaque. I've never had any issues so far because I spend an extra time cleaning my bars after the boil out to make sure all the wax is removed properly. So basically what I'll do is I'll cover everything up with heat shrink tape that I don't want to sandblast. And I'll sandblast, and then I'll do my opaque. The way I do my opaque is I'll actually use aluminum oxide to sandblast. In this case, I was using the GC Grady opaque. First layer, you put it like a wash layer, and you will cure it. Once you've cured it, you're going to put a second layer, but before you light cure, you dip it into some acrylic powder, and then you light cure that. Recently, I started, I sampled some, so shameless plug, obviously, some VITA opaque that I tried out at the, I did a course, a 2-day course at their campus, and they had some of their light cure opaque. Honestly, guys, I have better coverage with that stuff, and it's a little bit thicker. Now, the downside, because it's a little bit thicker, it's a little bit harder to apply, but the upside is because of that, it covered it up a lot nicer. I didn't have too many streaks in it. And I had some really good results. And I tried to unbond it, like I tried to pick at it. I was not able to do that. Let's put it that way. This is just some testing that I did. So this is when you try to bond acrylic directly to opaque when there's no fibers, and it just breaks off right from the opaque. But if you have fibers in there, it breaks off from the metal, and it's a lot harder to break away. But see, if you have proper room, this is a little bit too close. You want to have about, this is probably about a millimeter, 1.5 millimeters. You want to have about 2 millimeters here. So you set up the teeth right on the bar, you try it in, and then we go to processing. So there's a couple of ways to process. Like if you are going to put holes through the teeth right away, you can process with all 4 analogs in this case. But a lot of times I don't put access holes through my posterior teeth, because if you're going to be doing resets, or it's just when you're drilling holes and there's wax involved, it just creates a mess. So a lot of times I'll just do like anterior holes. We'll try it in with those, because if it's not screwing in down all the way with just the interiors, usually you're gonna have some issues. But if your implants are different levels and stuff like this, then you might have issues anyways. Just doing it with 2 screws, so I'll put holes through the posterior teeth as well. Okay, but if I'm doing just the anterior teeth, box it up, put it in a flask, boil it out, get the teeth prepped, get the bar prepped, get it processed. And then what I used to do the holes on the surveyor, and then I made this little jig thing, and then I started doing like a special burrs, and did a taper burr. All these things kind of worked okay for me. But what I did as of late, I started doing these little surgical guides. Basically what I do is I'll create a guide that fits right on top of the tooth. And when I'm designing them digitally, is I can make sure that it's exactly over the screw access hole. And I don't have time to show you guys the video, unfortunately. Sorry. But basically what it does is that I digitally design the guide to fit exactly over that area. And then when I just drill it with a burr, it just goes straight to the tooth, and through the tooth to the screw, and I can just pick things out with no problems whatsoever. At that point, you just get things remounted, get it all polished up and ready to go, and make sure you create some kind of splint. This one is a soft one, just a regular night guard, but a lot of times we'll do hard splints, because with the soft ones, they really, really want to chew into it quite a bit, and you just end up destroying things even more than they need to. All right, hopefully we're okay on time. Yep, 10 minutes left for questions. And I think we're going to stop right here, guys. That's pretty much my protocol within an hour and 20 minutes that I had to explain it to you guys.
Thank you, Eugene. Here are some more learning stuff that we have coming up over the next few months. What else? We do, for those of you that are interested, we are filling up our 2024 VITA Germany hands-on workshops. So if you guys are interested in any of those, please let us know. Also, we're having our SCAD event in Chicago this year in November. Again, if you guys are interested in that, we can get you some more information. If you guys have any questions about any of the products that Eugene talked about today or any of the VITA stuff, these are your local reps and they can help you out with that, especially pricing and those types of questions. If you've got any technical questions, you're welcome to call Jim or myself at the help desk. We are always happy to help and answer questions. And then, of course, if you have anything specific about the webinar you saw today or any specific kind of questions like that, you can reach Eugene here. And any other questions? There's one here that says, will there be a recording on YouTube? Yes, there will. It usually takes us about a week or so to get them up on the YouTube page. If you don't see it or you want a link to it, just shoot us an email and we'll get that over to you. Okay.
All right.
Well, thank you again, Eugene. I appreciate it.
Thank you very much, guys, for helping me do this. And thank you for everybody who's attended. Really appreciate you all coming, taking time out of your busy day to listen to me yammer about implants. And hopefully you guys got some good information out of it. And if down the line, we're probably gonna have another implant, two-day implant course next year, sometime next year at the VITA campus. And if you guys are interested in that, I'll post something on my social media that's gonna talk about that.
Excellent. Thank you everyone for joining us today. Thank you again, Eugene. We will look forward to seeing you guys next time. Again, if you guys have any questions, please feel free to call or email us, and we will see you soon.